So, welcome everyone to Carrying the Weight, addressing vicarious trauma in mental health professionals working with refugee and resettlement communities, a learning community hosted by the Resource and Empowerment Technical Assistance Center for Behavioral Health, or RMTAC. Thank you all for joining us today. This is session 2 of our 2-session learning community series on this topic. Before we begin, I would like to remind those who attended session 1 to complete the survey if you haven't had a chance to already. We'll be sharing that link in the chat for you to access. And if you missed session 1, you will receive the handouts and summaries from both this and the last session in the follow-up email. So today we'll be analyzing actionable strategies that organizations and individuals can implement to prevent and alleviate vicarious trauma and job stress. We hope that we can foster a collaborative environment where we can share knowledge, resources, and best practices through this learning community. And what differentiates a learning community from a webinar is the active learning, collaboration, and engagement. Through our collective experiences and expertise, we hope to enhance capacity, improve service delivery, and ultimately make a significant impact on the lives of those we serve. I encourage everyone to actively participate, share their insights, ask questions, and support one another throughout this process. Remember, the strength of our learning community lies in our willingness to collaborate and learn from each other. My name is Esther Rodriguez. I am a clinical consultant with RMTAC. I will be your host today. I'm excited to welcome you all to the second session of this learning community. I'm a master's level clinician with experience working with refugee and resettlement populations in a variety of settings, including human rights organizations, community-based mental health agencies, domestic violence shelters, and juvenile justice facilities. Later on in this session, you'll learn more about my experience with navigating and alleviating workplace stress. Now, let's take a look at our agenda for the day. And as you can see, we have a robust session plan. We're going to begin with an icebreaker, followed by introductions and an overview of the learning objectives. We'll then hear from our subject matter expert, who will address job stress, anxiety, and depression in mental health professionals. We'll then move into collaborative breakout sessions. The subject matter expert and 2 of the RMTAC clinical consultants will then discuss tangible evidence-based solutions to workplace stress and vicarious trauma for organizations and individual providers alike. During this session, if you need to briefly step away, feel free to turn off your camera until you return. So I'm excited to introduce our esteemed subject matter expert who we will be learning from throughout this session. Dr. Irma Perez is a clinical psychologist with experience assessing, evaluating, and treating clients from diverse backgrounds of various age groups with expertise in trauma, ADHD, behavioral disorders, anxiety, autism spectrum disorder, and intellectual disabilities. She'll be sharing her research on vicarious trauma and job stress, and we're grateful for her involvement in this learning community and her commitment to the communities we serve. We're also joined by Diana and Sonia from the Learning and Development team at RMTAC, who will be our producers today. That means they'll be working behind the scenes to make sure everything runs smoothly. If you encounter any technical difficulties throughout the session, please feel free to reach out to either of them via the chat. Their names and roles will appear on their videos. Thank you both. Now, I'd love to know where you're joining us from, so please share your location in the chat. I'm joining from Austin, Texas this afternoon. And I want to mention that, again, if you did not get a chance to register for this learning community before joining today, please also share your name and your email in the chat so that we can email you the follow-up materials from both sessions afterward. Okay, so I'm seeing that we have people joining us from Chicago, Sacramento, Detroit, Albuquerque, Grand Rapids, lots of people from Chicago, Phoenix, Arizona, Texas, North Carolina, Dallas, Kansas, Alabama, South Texas. Wonderful. Y'all can definitely keep sounding off in the chat. I'm going to go ahead and continue. But thank y'all. I'm glad we have people from all over. So let's get to know each other a little bit better and share our insights while we're at it with our icebreaker activity on developing a recipe for resilience. So imagine you're creating a recipe for workplace resilience. What three ingredients would you include? On the next slide, you're going to see a QR code on the screen. You can scan that QR code with your phone, or you can go to slido.com on your browser and enter the code 3550416 to provide your anonymous response. So again, imagine you're creating a recipe for workplace resilience. What three ingredients would you include? And I'll give you all a minute to think about what that would include. I see mindfulness, workload balance, positive team environment, self-care routine, chocolate, salsa dancing, GIFs, work-life balance, sleep, time with loved ones, emotional intelligence, empathy, tolerance. I love the chocolate and salsa dancing. I think that's fantastic. Joy, creativity, mindfulness. We have so many wonderful responses: break time, debriefing time, and communication, supportive colleagues. I cannot stress the importance of having a workplace that feels supportive. Patience, empathy, caffeine, definitely caffeine. Team snacks, 100%. I am not me when I don't have caffeine and I'm hungry. And celebration, self-care, support network. I'm loving all of these responses. I see that we have a few more people typing, so I'm going to give us just another minute here. A dash of courage, absolutely. Friendly colleagues and kind management, well said. Again, a supportive environment can do wonders. And then we have self-care, communication, and empathy. All right, I'm going to go ahead and move us along to the next slide. Which is where I'll give you all a review of what we discussed in session one. So during the first session of this two-part learning community, we named the unique challenges that providers serving refugee and resettlement communities face. Through a thorough review of Dr. Irma Perez's dissertation on job stress, anxiety, and depression in mental health professionals, participants learned about the impact that job stress, anxiety, and depression can have on providers and how this can negatively impact their clinical effectiveness, personal well-being, and professional responsibilities. And Dr. Irma Perez highlighted how job dissatisfaction can result in negative attitudes towards clients, which can also then result in lower quality or inconsistent care, and higher turnover rates, which could then lead to disrupted service continuity, gaps in care delivery, and weakened support for clients. And through collaborative discussion, participants were able to identify their personal experiences with job stress and vicarious trauma, identifying organizational practices that contributed to them. Additionally, Dr. Irma Perez explored the data from her dissertation and how the impacts on personal well-being disproportionately impacted women in the field of behavioral health due to gender roles, stereotypes, and social cultural norms, while also acknowledging the significant underreporting in men. We also learned about the definition of vicarious trauma under the umbrella of workplace hazards for behavioral health specialists, which also includes secondary traumatic stress, burnout, PTSD, and compassion fatigue. What distinguished vicarious trauma from these other concepts is that it stemmed from recurring exposure to others' traumatic experiences by attending to the accounts of the events of their lives. And it was marked by a change in worldview, with providers becoming more cynical or fearful, becoming more appreciative of what they have, or both. Signs and symptoms included emotional shutdown, emotional dysregulation, difficulty concentrating, and even physical problems like aches, pains, or compromised immune system. At the end of the session, we asked participants to complete the workplace stress scale, and write a short letter to a new provider entering this field and the intention of offering wisdom or encouragement in relation to vicarious trauma or job stress. And I'm going to link those in the chat for y'all as well, so you have access to them, because we'll be reviewing that later in the session. So today we'll be bringing together teams to collaborate, gain new perspectives, and learn the best strategies for addressing these complex issues that result from vicarious trauma and job stress. And during today's session, we're going to collaborate again with Dr. Irma Perez to learn about her research with behavioral health professionals working with clients in resettlement communities and address the implications from her findings. As I mentioned earlier, this learning community is intended to be engaging and collaborative. So you're highly encouraged to take advantage of the knowledgeable individuals in this session by being an active participant. I'm going to go ahead and hand this off to Dr. Irma Perez. Thank you so much.
Hi. Can you hear me? Okay, awesome. All righty. Well, thank you again for allowing me to be part of this this training and this workshop, and for all the things you do for those mental health providers out there. I think it's important that we work together to provide, not only to get each other's insight, right, but to provide some goals for the future, especially in the field that we serve. I think that was my goal all along. I knew that when I started the doctoral program, vicarious trauma was going to be my subject of choice for my dissertation. It did change as far as goals throughout my tenure and throughout the journey in the doctoral program, but all in all, it still did come back to vicarious trauma. Like I spoke about it last week, or I think a couple of weeks ago. It was my passion, and working with my clients is something that I think we all take very seriously, right? But I also know how important it is for us as providers to be at our very best so that we can provide the very best services for our clients. So my dissertation the name is Job Stress, Anxiety, and Depression in Mental Health Professionals, and it's an examination of experienced vicarious trauma and gender differences. Like Ms. Rodriguez spoke earlier, we talked the last time we spoke, we discussed vicarious trauma, the umbrella that it falls under, as well as some of the implications. So the goal of my study was, it was a quantitative study, and it examined how job stress, anxiety, and depression amongst mental health professionals and how they were impacted if they had experienced vicarious trauma, as well as gender differences, and how those gender differences also impacted these mental health professionals, right? The goal was to expand that collective knowledge base that we acquire from doing research, right? And the outcomes allow us to identify theoretical and the practical importance and contribute to the designation and implementation of those support systems, trainings, to include gender-sensitive interventions with mental health professionals as well. So we'll go on to talk a little bit about the research questions. My research questions, I had 3 research questions. The first one was, what was the impact of vicarious trauma on gender and a linear combination of job stress, anxiety, and depression among mental health professionals? It is noted that there's limited research and published findings on the impact that gender has on mental health professionals following that repeated exposure to trauma and experienced vicarious trauma, further establishing that need for exploration and continued research. The second one was, are there significant gender differences between job stress, anxiety, and depression amongst mental health professionals? Again, recognition of how this experienced vicarious trauma and gender differences influence job stress, anxiety, and depression. It's necessary so that we can begin addressing the associated implications, right, that affect mental health providers at large. And the third was what is the impact of vicarious trauma on job stress, anxiety, and depression amongst mental health professionals? So all of the questions are a little bit intertwined, but they all aim to answer um, that interaction between them, right? So, like we talked the last time, it is important to understand the gender differences and the vulnerability to life stressors such as job stress, anxiety, and depression that is increased based on individual beliefs, cultures, values, even just the identified social norms, whether it be in the community that you're in or in your overall culture, right? As well as those universal and societal expectations. Okay, so let me talk a little bit about the research demographics, right? So all in all, we sought 100 participants and these participants had to be mental health providers that worked with um, in a mental health setting with victims of trauma, right? And what we did was we used a social media site Qualtrics, and we also used the recruitment flyers. So on the recruitment flyers, we placed several social media sites that were sent to individuals separately. And then also we use this Qualtrics to share the scanning code, something like what we did earlier with the um, to share the answers. I'm not sure what they're called, but we used Qualtrics and the social media sites, right? And then as well as through my tenure as a clinical director and working as a clinician, I was able to meet a lot, work with a lot of different agencies and organizations. So I was able to share those flyers with them as well, and ask them to share with their colleagues as well. So that's more or less how we were able to share the study. I felt like I told one of my friends, I feel like I'm running for office because I was out there, you know, just selling this study. Look how important it is. All of us that are mental health providers, this is going to be, you know, this is your time. And of course, it was going to be anonymous. So I mean, nobody's going to know, but your insight is going to help. And so getting that information out there was really, really important, right, as a starting point. All in all, of the 100 participants, we had 88 mental health professionals that did end up completing the four questionnaires that were required for the research, right? Um, Again, the population were individuals with a bachelor's degree, right? And of those, of those, we had 22 individuals that had a bachelor's degree. 25% of them had which were 56, had a master's degree, and 63.6%, and then 10%, 10 of them with a doctoral degree, which is 11.4%, right? The average age of the participants was about 39 years to 39, 5 months. Um, More or less, right? The instruments that we used were the general work stress scale, the Beck anxiety inventory, the Beck depression inventory, and the trauma attachment belief scale. And they were not very long, but these are well known in the community for those of you that have used them. If not, I do recommend them because they do provide some good insight. Okay, so the results of the test of the testing and the research, what we wanted to do was be able to get an opportunity to inform the mental health profession, right, and the discipline of these findings, not only to contribute to the education, but we wanted to also be able to implement mediate. We wanted to find interventions that would help mediate and prevent those individuals from either experiencing job stress, anxiety and depression, and also being aware of what vicarious trauma is and being able to recognize the signs and symptoms to prevent those kinds of events from happening, to prevent, to really provide those mental health professionals with what to look out for, right? And I know throughout the study, I learned a lot about job stress, anxiety, and depression, and how it impacts females and males differently, how it's manifested very differently as well, right? And so also, as well as how a lot of times it is masked or it's put aside because sometimes people might feel that it makes them less of a therapist, or males were struggling with feeling that they weren't strong enough and things like that. It really allowed a lot of insight also as to what the stress that females experience, right? And the different ways that it's manifested and the different implications it had on work life, home life, and community life. So the outcomes were as I had thought, but I just didn't realize the amount and the extent. So the outcomes do confirm and extend the knowledge in the discipline, and they reiterate the need for that continued research based on the elevated possibility that mental health professionals have of experiencing vicarious trauma. Um, the findings indicate that trauma did have a statistically significant impact on mental health professionals' levels of job stress, anxiety, and depression, right? Descriptively, vicarious trauma levels of disruption showed higher scores for all three dependent outcomes. And of the 88 participants that did complete the forced questionnaires, 51 of the participants who had reported experiencing vicarious trauma also reported an increase in job stress, anxiety, and depression, right? So the outcomes indicate that not only that statistical significance, but it also goes to show the impact, right? The impact that and the roles, how our role as mental health professionals, how we are impacted by the trauma that we hear on a daily basis. Some of you may work in shelter settings, some of you may work in community settings, right? Either or, the majority of the time, we're here to help somebody that's in a really going through a really difficult time, or dealing with some very stressful things in their life, right? And our role is to help them get sort of unstuck, right? And help them to start to see things in a different light. But in order to do so, we really have to take in everything. We have to provide that genuine empathic response to their needs, right? And so the reality is that the reality of the role, it's that in the process of demonstrating that genuine and empathic attunement to our clients, we also have to be understanding and cognizant of the fact that vicariously, when we see the world from that client's point of view, we're also putting ourselves in that situation, right? And so we have to understand how that impacts us. We have to understand how we're going to process that information as well, and how we're going to mediate it so that we don't take it home and it doesn't become inhibiting or impacting us in a negative way, right? So I thought that was the most important, right? Is reality of the role that we play as mental health providers in assisting individuals that are experiencing trauma. And also I elaborate a lot also on the shelter settings, because I worked in many shelter settings and I've worked with many disciplines. And it's not only the clinicians, right, but case managers, youth care workers that are working with these children, and are aware of some of the things that they've gone through, and how they take that home and how they process that information. Um, So aside from recognizing the reality of the role and the impact, it is important to understand that there is much more research that needs to be done, right? The results of the study do inform the discipline. However, there's a lot more that needs to be done. Some of the research indicated that depression overall is a global health priority, accounting for 10% of non-fatal diseases worldwide. That's how big that is. And we really need to see it for what it is and the impact that it has. Okay. So throughout the study, again, in a dissertation, I have the opportunity of working with a chair and a methodologist, right? So my chair is involved in ensuring that the content is correct and making sure that everything that the research that I'm doing is coinciding with my study. And that was really, really good. And then we have a methodologist who really helps out with the quantitative studies and the numbers and all that stuff, because I'm not good with that at all, right? But they really guided me a lot, right? So through that process, um, one of the things that I was concerned about was what are some of the study limitations, right? How am I going to be able to provide a generalized outcome, and what are some things that can impact it both internally and externally, right? So one of the things that I did identify as a limitation was the limited demographics, right? Yet I do know, like I said, I did share with several social media sites, several networks that I had met with individually, that I have met through my personal journey and my career journey, right? But that still limited the scope, right? I cannot say that we went to other countries to do it, that, people in New York or California, I see a lot of people from Chicago, all these people that were logging on, right? I didn't get too many individuals in those areas. So there is that limited demographics, further demonstrating that need for continued studies and demonstrating the limitations. Another one is that was a limitation, and I had initially placed it in my dissertation, was there was a gender inequality. Of the 88 participants, only 15 were male. So I thought, wow, that really is a limitation. But again, through the guidance of my chair and my methodologist, I was geared to like, hey, let's really look into the ratio of male to female providers in the mental health field, and see if that really is a limitation, or is there that gender inequality of the differences. And so in my research, it was found that the in the psychology profession in many Western nations, it is female dominated. Through several of my research had also that demonstrated that this was not only a female dominated profession, right? But there was limited males that were therapists, counselors, or in the mental health field, right? So there shows again those disparities, and so that also shows to how come more investigation and more research is needed to explore those gender based impacts, and also to inform effective, equitable interventions and also support strategies. What can we implement to provide that support system? Also, some of the gaps in the literature that were identified were that vicarious trauma and job stress and gender on job stress and anxiety and depression have also been ignored. When I did find the information, it was very limited. A lot of it, when it came down to depression, when I was looking into depression with males, that was very little information, yet we were having high suicide rates in males, right? So according to one of my research outcomes, it did indicate the the discordant relationship between men's low rates of diagnosed depression and high male suicide rates, which again talks to the need for more research, enhanced assessment of these kinds of symptoms among male therapists, mental health professionals, and being able to detect it as well as provide those mediating interventions.
Thank you so much for sharing the results from your research study and all of your expertise, Dr. Perez. We're going to continue to hear from her once more before the end of today's session, so we'll get a little additional insight. But before we do, I do want to hear from all of you. So we have a poll up on the screen, and I would like for you all to share the numeric results from your workplace stress scale. This was what we sent you all after the end of session 1. If you weren't able to complete it, I did link it in the chat if you'd like to do that now. These results will be anonymous, so you can select the range that aligns with your score. And y'all are already filling it out, but again, you can scan that QR code in the top left corner of the screen, or you can use the browser and go to slido.com and use the code 3550416 and let us know your results. And we're getting some answers. It's looking like the majority of people are at 15 or below. And then 21 to 25. And then 26 to 30. And as we're getting more and more responses, 15 or below seems to be getting the most responses. Yeah, and that number just keeps growing. I'm gonna give just a couple more seconds. But I just want to thank y'all as you're entering your responses for your candor. And as you're entering in those numeric responses, I do want you to think about the reasons behind your results. And we have another poll after this. The question is going to be, how do these results align with your day-to-day experiences? So remember your results from your workplace stress scale. And I want you to think about how these results align with your daily life. And you can feel free to enter your responses in the Slido chat. And again, if you didn't get a chance to complete that scale, we've linked it in the chat for you. I know I can see people typing away, so I'm waiting a few minutes to see what responses we're getting. Our first response says it was a little surprising to see how high my number is. It made me realize that everyone processes stress at work differently. Another person was surprised because they didn't think that it would be that low. So I noticed the responses we have are people feeling surprised. Does anyone feel like the response or the result that they got confirmed what they already knew about how they felt about their work? Yeah, someone said it was expected. I think my results also were aligned with how I experienced my work-life balance and my daily work tasks. I wasn't really surprised. I didn't feel like my number was too high or too low. It felt very accurate to what my experience is at work. We have a couple more people typing, so I'm going to let them finish their responses. Yeah, a couple other people think they got an expected response as well. It also shows us the accuracy of that workplace stress scale. We have another response. It aligns appropriately. I often feel that the negative experiences are offset by the positive ones. I am glad that the majority of the peers do not feel severely stressed. I agree. I'm pleasantly surprised that the highest number on that scale was mainly people scoring lower than 20. I'm going to give just one more minute. Yes, confirmed what I knew. Felt good that it was low, even though there are some stressors. Working with a good team helps alleviate stress. I agree. I'm sure that other people resonate with this, but there have been plenty of times that I've worked at places where the work was stressful, but the team was fantastic, and I stayed because the team made me feel supported. My supervisor, my coworkers, my colleagues, that can sometimes offset the stress of like a high caseload or highly traumatized clients. And I'm sure others agree. Oh man, we've got a few more participants typing. I want to wait and see what we have, what responses we get. Because what happens is once we move to the next one, the slide will pull, and so I want to catch everyone's responses. It was as expected and feel I need to slow down and breathe. I feel like my stress has changed now versus last year. I can absolutely resonate with that. My stress levels last year were very different than what my stress levels are at now. I felt like my stress levels last year were actually higher than they are now. All right, just in the interest of time, I am going to go ahead and move us forward. But if you do have any additional thoughts, I'm going to ask that you all share that in the chat. I'll read the last one we got. My team culture is great, keeping my daily stress low. But this scale didn't evaluate system issues, which are causing incredible stress. Absolutely. It's important, as we saw in Dr. Irma's presentation, to consider the results, but also the limitations. So thank you for that insight. I'm going to go ahead and move us forward then. Thank you all again for participating in that poll and for sharing your experiences. Next, we're going to be watching a short video in which I'm sharing my personal experience addressing my symptoms of secondary traumatic stress. In session 1, we listened to my experience with job stress, and today we're going to watch the entire video and see how I was able to overcome this experience. And although secondary traumatic stress is different from vicarious trauma, there is a significant amount of overlap between vicarious trauma and secondary traumatic stress, burnout, PTSD, and compassion fatigue, as we saw in the Venn diagram presented earlier in the session. But what I want you to focus on as you watch this video is anything that resonates with you. Hey, I'm Esther Rodriguez. I'm a clinical consultant at RMTAC, and I'm going to talk to you a little bit about my experience with secondary traumatic stress when I was a home study and post-release services case manager. I'm going to start with some of the signs and symptoms that let me know that I was experiencing STS. The biggest one really was actually my somatic symptoms, which were my medical and physical symptoms. They were manifestations of my emotional distress, and it was a really hard time for me to maintain a healthy appetite. I was constantly feeling nauseous. I was throwing up a lot, and I ended up in the emergency room and urgent care several times. And I realized it was a symptom of STS when the medical professionals could not find a medical or physical cause for my symptoms. And then it became increasingly obvious too that I was experiencing compassion fatigue towards my clients. I was no longer responding to them with caring and empathy. I was more annoyed and frustrated, both with the system, but also just with the experiences that they were having. And I know that if I would have continued to ignore my symptoms, my compassion fatigue would have just gotten worse. And I would have experienced worsening burnout, where I was having a hard time staying motivated and completing work tasks and maintaining relationships with my clients, being supportive, and even completing things like progress notes and reports, just because I did not have the energy, I didn't have the capacity to stay focused on what I needed to do in order to support my clients. And if I would have continued to ignore the symptoms of STS, I know I would have also experienced a worsening or a deterioration in my work and personal relationships, because not having the energy and being so fatigued from the burnout, the compassion fatigue, and the STS, I just didn't have bandwidth left to be present for my relationships in and outside of work. Eventually, I made the really difficult decision to quit my job, because I just knew that when I took a step back and I looked at my life, I needed to make a decision about what was best for me in that moment. And if I continued to do what I was doing without making a significant change, I was not going to be prioritizing my well-being, both physically and mentally. But now that I know the signs and symptoms of STS and I can recognize it in myself and others, I really take advantage of things like my employee assistance program, because having those counseling sessions to be able to process what I'm going through, especially related to work, allows me to really just hold space for how I'm feeling and process that with someone who's there for me and understands what STS is and how it can be managed in a healthy way. But in that experience that I had, I think that more engagement for a fully remote team would have been helpful in not only managing our caseloads and sort of reviewing referrals and services for our clients amongst the team, but also engaging outside of work, having conversations and connections with my colleagues beyond just being case managers. And on a more personal note, I think also really taking a look at and developing coping skills that were actually effective in supporting me and my needs, which looked like tapping into my social support system, reaching out to my personal connections as well as my work connections, and letting them know what was going on so that they can show up as caring and supportive for me. That was what really made the difference. I did want to mention that it is part of one of our online learning modules in a series about trauma-informed care that was developed by RMTAC. So if you're interested in learning more about it, you can find more information on this and other topics through the RMTAC website under the Learning Hub. Our producer, Diana, has linked that in the chat for you. And now in a moment, we are going to be transitioning to our small group sessions. As we discuss solutions, it's important for us to know that what works for one provider or organization may not work for another. So let's combine our shared experiences so that we can become better equipped to support ourselves and each other as we serve those in need. Wonderful. Thank you all so much for your conversation and discussion. At this time, we're going to take a few minutes to hear from each group. So we'll start with group one, and Diana, you're going to have to help me with this because I can't remember my group number.
Group one was Dr. Mutsa, group two was you, group three, Dr. Z, and group four was Luce.
Okay, thank you so much. All right, Dr. Mutsa, you can go ahead and go first for us.
Wonderful. Thank you. So in our group, some of what we discussed in terms of what has been helpful getting through workplace stress and vicarious trauma was similar to what was noted in Esther's video, was just that space of like getting together outside of work, detaching and taking small little breaks. Those are some of the things that have been helpful. We also talked about for those that have a commute, using your commute, using that drive home to do something that's very intentional with just like decreasing stress. Things like listening to podcasts, listening to music, sometimes even just driving in silence can be helpful. So those are some of the things that we talked about. Also just going and grabbing coffee or like boba tea, all of that. It's just a nice little break. In terms of boundary setting techniques that we discussed that have helped protect emotional well-being. We talked about how helpful it is for those who work from home having designated workspaces, because that allows you to then, when it's time to like be done with work, you actually like leave a specific space and you can kind of leave work at work per se. It's a little bit more difficult when you work from home and you want to kind of detach, but home is also work. So we talked about that being helpful, as well as like if you have a work phone, not leaving it out where you can see it and kind of see messages coming in, emails coming in. So setting that boundary to really just like be able to detach a little bit from work. And then in terms of organizational changes that we would advocate for, we talked about like lighter caseloads for those that have like assigned caseloads, and that it would be nice to hear from leadership and organizations that it's okay to slow down, it's okay to take a break. Often feeling like you don't necessarily have the permission per se to do that. So it's nice to kind of hear from leadership that self-care is important and that they encourage it in some capacity. So that's some of what we discussed in our group.
Excellent discussion. Thank you for summarizing that, Dr. Mutsa. I think some of the responses in my group align pretty well with what your group was discussing as well. We talked about a lot about the importance of self-care and how setting that time once the workday is done, whether you work from home or not, that once the end of your day has arrived, it is now time to focus on family or focus on yourself, to sort of reduce that workplace stress. And then we also talked about identifying limits. I personally mentioned being able to say no, or being able to set like time frames, especially for those who are working directly with clients, letting them know what hours you're available and when you're not. And then within the same realm of self-care and wellness was being able to take mental health care days and not feeling guilty when time off is taken. And then using peer support or supervision groups as a time to process any difficult experiences. And then lastly, when it came to discussing organizational practices, we had some really awesome ideas around using art and using retreats for teams to be able to disconnect and separate from work, while also being able to explore their emotions and use resources for the well-being of staff members. So that was we had lots of ideas, and those were just a few of them. But I thank everyone in our group for that discussion. I think the next group we had was group 3, which is Dr. Z.
Yeah, can y'all hear me?
Yes.
Okay, so in our group, we had a lively discussion. We basically started out with the fact, that we use that we one of the big things that we implemented was having the after hours phone call be eliminated. So phone was after hours, no more phone calls, just gotta like end the day and just be done with it so that we can go home and just decompress from the day because this stuff is really very difficult to work. And then also on top of that, we use other things like, taking a long walk after the day is done, take a long walk with the dog, or going to the gym and working out, or hanging out with family, hanging out with friends. Just using those types of distractions to kind of just, really kind of just take the day off, or to go home and watch like TV shows that make you laugh to remind yourself that there's still beauty in this world versus the difficult nature of the work that we do, especially with like when you deal with, very difficult stories having to deal with, like, say, immigrant children, injuries, death. I mean, just unbelievably difficult stuff. Where there was one person in my group who was talking about just unbelievably difficult. Not obviously she wasn't giving full details, but she was hinting at that the work that she does is extremely hard, and so I can just empathize with that. I mean, I don't know what she went through, but she's the one that said that the um comedy really helps her out. So I really appreciated that part of it. Um, in terms of in terms of group organizations and organizational support, just having an organization that will actually reach out to you when there's a difficult situation. If obviously offering help every time, anytime, just before you may need it even. So having an organization that really helps out in terms of reaching out to you before you go through it, or making sure remind you constantly that those resources are available to you, and to not feel guilty by using them, or to not feel guilty about reaching out in order to employ them, because because this work is so hard that helping you to keep yourself going benefits both the organization and the clients. So that was a lot of our discussion in terms of supporting the providers that do this work on a daily basis.
Wonderful. Thank you so much for that. And last we have Luz, who was in group 4. So let us know what y'all chatted about.
Yes, we actually have somebody representing our group. That's Miss Lutna. She's going to represent on behalf of Group 4.
Perfect. Thank you.
Thank you, Luz. And hello, everyone. It was a very insightful discussion, as always. And in terms of the actions that help with dealing with vicarious trauma, we discussed setting very clear boundaries. One of the members mentioned, once they're out of work, they lock the office door, they leave the laptop home. I'm not at home, at office, and not bringing work at home. And another participant mentioned even limiting the exposure to traumatic images or programs that they're watching outside of the work hours, so that it's not a reminder of what they deal with every single day at work. So kind of aligning with maybe, changing what we watch, as someone mentioned previously about enjoying comedy programs. So that was another recommendation. As far as the recommendation to organizations were concerned, someone mentioned having lower caseloads, because it is often that case managers have a huge caseload. And although this wasn't mentioned, I think depending on the background of your clients and your demographics, 15 may, even if someone has 15 or 20 caseloads, it may represent two different types of energy level that may be required to cater to your client's needs. So, and obviously having administrative support. We always have at my organization an open door policy. So we can reach out to our administration for any reason, if it's something that we need assistance with. And if we were to have like a wellness initiative in our organization, someone mentioned, and it was a really nice idea to have like a quiet sensory room where you could have maybe like Zen type of atmosphere, slow music, a nice dim lighting, very peaceful space where you can just come and calm yourself, and any sensory stimulation. Also, I think, well, I was going to mention that I'm so in for meeting with our colleagues after work hours for even coffee or just some form of a weekend gathering or something. If not every, like bi-weekly, monthly, but I like it having regular. And so that was just some things that we discussed. Very insightful. Thank you, everyone who participated. Really enjoyed hearing from everyone.
Thank you so much for sharing those insights. And I share that same sentiment. I'm grateful for all of the discussion and interaction with the content that everyone's had so far. It's very clear to me that the discussions during the breakout session were fruitful. So let's go ahead and move on to our next section. We're going to welcome back Dr. Irma Perez, and we're also going to welcome our RMTAC lead clinical consultant, Dr. Mutsamajiro. And we're going to have a conversation about the solutions and strategies that both organizations and individual providers can implement to proactively minimize the effects of vicarious trauma that can be caused by workplace stress and address the symptomatology at the first signs of them. So Dr. Perez can kick us off.
Hi, welcome back. I was also able to be part of Esther's group talking about those things that we can do to help us not bring home all that stress and sometimes anxiety that's associated with work, and a lot of really great feedback. I think that when we're able to collectively come together like that and discuss what has worked for other people, it really allows us to think maybe I could do that as well, and try to incorporate that into our daily routines. Like I said earlier, that is something that has also worked with me in the past when working with teams. So I think we're going to go into and talk a little bit about some solutions and strategies that we can advocate for in the organizations that we work for, organizations that we work with. In my case, is working with. So I have the opportunity right now of working with several different shelter settings. I'm also working in the community, and I'm also working with the juvenile population as well in Cameron County and Hidalgo County. So I've gotten the opportunity to work in all of these different settings and meet with the different administrators and see how they provide the best services to the population that they serve, right? So let's start with the first one, right, is leadership buy-in and development, right? So we want to understand the stakeholders' priorities, right? We want to understand where their priorities lie, right? But we also want to let them know and inform them how an evidence-based and trauma-informed changes, how they can lead to positive business outcomes, right? How they can improve their retention, how they can get engaged, and how they can reduce that absenteeism, right? So when we talk to, I know that in the past, like I said, speaking with stakeholders and those in the higher ups that are not necessarily dealing with the clients themselves, it's really to talk to them about the impact, right? The personal, social impact and occupational impact that these stories, how they impact us and how they affect us, right? How they affect our services that we provide, the services that we provide, right? And if we're able to share with them and really, like I said, start off with psychoeducation, right? Just education, right? Educating them on what is, vicarious trauma, how it can be, maybe they've heard it under a different name, maybe they've seen it and didn't know exactly what that looked like, right? So providing different pictures of what vicarious trauma looks like under the umbrella that it falls, providing that information, right? And then letting them know, right? So if we implement these changes, what are some of the things that we can see? Improved retention. Well, if we have a clinician, we have a mental health provider, we have a therapist that knows that they can go to their supervisor, they can go to the higher ups, and they can talk to them a little bit about maybe something personal that they've been going through, and know that they're going to be supported by that. Know that they know what I'm talking about when I'm saying I'm experienced vicarious trauma, then they're going to be more likely to go to that person or to that higher up and share their concerns, and not necessarily just say, you know what, these people are never going to get it, I'm just going to have to find somewhere else to go, right? So that provides them with an option. That's improved retention. We're not only going to keep that clinician on board, but we're going to show her that we support her and the likelihood of her providing better services is also going to increase, right? It's also going to reduce that absenteeism in the sense that instead of just not coming to work, they might come to work and say, you know what, based on what's been going on, why don't we talk a little bit about my schedule? Maybe on Fridays, this seems to be my more difficult days at home or, with the kids. And maybe on this day, I can work a little bit less hours and work another day, a little bit more. Just basically communicating, collaborating with your supervisors with the knowledge that they are informed about what vicarious trauma is, its impacts, the implications, and that they're willing to support the team member. So I feel like that in itself is going to reduce absenteeism greatly, right? And then the second one is providing that formal training for the organizational leaders. Again, that formal training is going to start with psychoeducation, right? Providing them with that training. But I think a lot of that formal training is also not only the psychoeducation, but really putting them to do a hands-on case by case, giving them a case to handle themselves. If this was your problem to solve and you had to deal with this client, not give it to your lead clinician, not give it to your lead case manager, how would you actually do that, right? How would you go about mediating or helping this client deal with that stressor or that trauma, right? So just basically giving them the dynamics of what our role is as a therapist and so that they can understand the underlying roots of what vicarious trauma is, how it's actually acquired, right? They're going to start off with one cases and then we'll say, now imagine 20 a day. Because at one point, for those of you that have worked in shelter settings, there was times that our numbers were so high that's how many 10 to 15 clients we were seeing a day. And each one of them had an SIR, or now they call them CLEs, or they're called different things, right? But they each had a story. And even with the numbers low, let's just say we had two, but we had two very complex cases. Those two complex cases came with a lot of information to really take in and process and say, okay, this child is going to need additional help, right? Or this client is going to need additional resources than the ones that we would normally provide, right? So that's where I feel that introducing this formal training, hands-on training, and having the leaders understand the dynamics and the roots of it will really allow them to gain some perspective on it. And then modeling the self-care behavior, right? You want to encourage our staff to prioritize wellness. And part of that is, we talked about it in the group, somebody talked about, mental health days, really understanding when we need to take a mental health day, especially when, again, we might be having a client that is very high maintenance or needs a lot of guidance and support, right? So being able to talk to your supervisors and that supervisors have an understanding of what their clinicians, what their team members need, and when it's okay to say, all right, if you want to go ahead and take this day, go ahead and do that. Make sure that you take the time for yourself, and that way you come back 100%. Other than coming back and being really fatigued, really frustrated, and really unable to provide the most adequate services for our team members. So modeling those self-care behaviors, we talked about it in the team, in the groups, and you shared as well, Ms. Rodriguez, about, just turning off your phone after certain hours, right? Knowing your limits, limiting your mobility, not always being able to say yes, and understanding or knowing how to say no, right? Well, knowing how to say no, we can't always do that, right? So sometimes we have to model those self-care behaviors and encourage our staff members to do that. And there's a lot of different ways to do that. Again, one of the things that I shared within our group was, at the end of our weekly meetings was taking the last 10 to 15 minutes to do a quick check-in, check in, how's every team member doing? Is there anything that you guys are struggling with? And then just allowing for informal feedback within the team, and sometimes hearing others' solutions will help that individual that maybe they had not thought about that. So I think that those were really good ways to model that self-care behavior, as far as, including the team, sharing your concerns, and then getting that feedback. The next one is, I think these are also mine, right? The work stress solutions and strategies. Okay. Self-care policies. I'm sorry, I know I talk a lot and I go into it, but implementing these mandated self-care policies, such as wellness breaks or requiring personalized plans. Again, I think these personalized plans, I think those are very, very important. As I saw through my research, those gender differences and the associated with the gender roles, also those assigned expectations and cultural norms, they contribute to elevated numbers of concerns within males and females. Most was seen within females. So let's just say that we have a female one of our team members that recently had a child or has 2 or 3 small children, right? Really sitting down and speaking with her and saying, how are you doing? We know that this can be quite a responsibility. What is some things that we can do to help you, right? So we want to make sure that when we do have those individuals that have things going on in their lives aside, that may be a little bit more or be more time consuming, that we're able to implement a policy where we're going to address those needs and provide that support. Rotating that high crisis cases among staff to prevent those emotional overloads. Making sure that we're checking in and looking at those numbers to make sure that we don't have a clinician that's being overwhelmed with so many cases or so many clients that they're unable to care for themselves. So we want to make sure that as leaders or as supervisors that we are monitoring those caseloads and ensuring that there's equality, right? And then allocating time for documentation. I know that was one thing that I spoke with one of my colleagues that worked in the same area, is that we do know that when we have those clients that are complex or require a lot of additional assistance or resources, then the documentation for those kinds of cases is going to be a lot more lengthy. So allocating that time and recognizing the amount of time that's going to be needing that. So that might mean pulling or lowering that caseload or taking some of those roles and responsibilities on for ourselves as supervisors and leaders. And then comprehensive training. We want to, again, I feel like sometimes I'm redundant. Those real world scenarios, those hand-on exercises that I was talking about earlier, really getting them involved, right? So that we can challenge those negative connotations and normalize conversations about vicarious trauma. But in order to do sometimes we really got to put them into that role of a therapist, of a clinician, mental health professional working with victims of trauma. And then incorporating those gender sensitive interventions, right? And modules to address unique stressors faced by different groups. So identifying the unique stressors that each group is facing. Again, like I said, a lot of the research that was addressed in my dissertation talks about how females are impacted more. But what was interesting to understand was also, even though males are less likely to talk or share or express any symptoms of depression, the suicide rates are increased for men. So that shows right there that we're not only lacking research, but we need to look more into that so that we're able to provide a individualized support system for males and females in the work area and working with victims of vicarious trauma.
Thank you for that information, Dr. Perez. So in addition to the leadership buy-in and development and the workload and policy adjustments and the comprehensive training, another organizational level consideration that can also positively impact the individual provider's experience with vicarious trauma includes providing adequate supervision and support. This involves equipping staff members with knowledge about vicarious trauma and providing them with structured skills like self-care, mindfulness, and boundary setting, along with regular supervision and reflective practice. And this involves collaborative professional relationships that use guided process of reflection to promote the practitioner's development and improve the quality of services. Instead of focusing on tasks or oversight, it emphasizes discussing thoughts, feelings, and experiences to build skills, increase self-awareness, and manage the emotional aspects of work. Supervisors facilitate this by creating a safe and trusting environment, actively listening and asking thoughtful questions that can help the supervisee find their own solutions. By creating a working environment for staff members to be able to talk openly about their work, emotions, stress, and challenges helps them to feel safe, supported, validated, and appreciated. The supportive supervision and peer groups allow staff members to be able to share their challenges in a comfortable way, learn from each other, and find solutions together. In addition to those organizational level considerations, we also included solutions and strategies for individual providers. So we can move on to the next slide there. Programs that teach about the warning signs and symptoms of vicarious trauma, secondary traumatic stress, compassion fatigue, and burnout have shown promise in reducing negative psychological symptoms, including anxiety. And as providers become more aware of the manifestation of vicarious trauma, they can more easily identify it in themselves, meaning that they're going to be more likely to seek treatment and set healthy boundaries to manage their work-life balance. In addition, taking the time to learn your own triggers and personal manifestations of vicarious trauma can lead you to develop the self-awareness that's necessary for identifying the early warning signs. And that way, you know when you need to take a break, ask for support, and take care of yourself. I'm going to hand it over now to Dr. Mutsa.
Perfect. Thank you, Esther. So in continuing with strategies for providers, I'm going to focus on building sustainable resilience, not just some strategies that kind of provide temporary relief, right? So the first strategy is creating a personalized self-care plan that involves scheduled disconnect. So a lot of this came up in some of our breakout rooms. And so for us providers, especially those who work with communities facing high levels of crisis, that line between work and personal life can really be blurry. So scheduled disconnect really simply means just giving yourself explicit permission to turn off, right? So meaning no work emails, no late phone calls, no quick little, let me just respond to this client message. This is not about being less committed, right? It's about preserving your capacity to show up fully the next day. So for those of us who serve displaced communities, emotional availability is essential, but it has to really be balanced with boundaries. So protecting your personal time allows for you to recharge so you can continue to offer high quality and compassionate care without the burnout piece. The second strategy is developing a mindfulness routine, right? So mindfulness doesn't have to be like hour-long meditation. It can just be as simple as a 2-minute grounding exercise in between sessions, or a breathing technique after a difficult intake, or maybe just even taking 30 seconds to just check in with your body before starting your day. So a lot of us who work with traumatized populations, we carry tension in our bodies without even realizing it, right? And that mindfulness can help you, can help interrupt that cycle. So it can help to regulate your nervous system, help to reduce reactivity, and enhance your ability to really be present with clients, especially when you're navigating really intense or emotional content. Um, and then also using mindfulness apps to support consistency is great. So a lot of us, we know what to do, right? We know what to do to take care of ourselves, but that consistency is where things tend to fall apart. And apps can really help to bridge that gap, right? So you all may have heard of apps like Headspace, Calm, or Insight Timer. They can help give you some sort of structure. So they can help provide short practices that you can implement, reminders, tracking your progress, and sometimes they can also really help you create culturally responsive meditations. So for those of us who work with newcomer populations, these apps are really helpful because they can help you model accessible like well-being strategies that you can also share with your clients who may be facing language issues, transportation issues, financial barriers, all of that. And lastly, physical, social, and creative outlets are key as well. So vicarious trauma, as noted earlier, it stays in the body. So physical movement, like walking, stretching, going to the gym, that can really help to release some of that accumulated stress. Um, Social connections, which we also discussed too, that's also really, really important. So talking with trusted colleagues, debriefing with your supervisors, or just simply spending time with your loved ones can really be grounding. And providers who work with newcomer communities, we often carry that sense of responsibility or emotional heaviness, right? So staying connected with people who help you to refill your cup is really essential. And then there's also creativity. So activities like writing, music, cooking, dance, art, all of that creative expression can really help you to process emotions that we may not have the words for. So a lot of us who are providers in this space, we may be from immigrant backgrounds ourselves, right? So creative outlets can help you to reconnect with your culture, your identity, and find joy in just like small little moments. So to summarize, vicarious trauma, it's not about just doing one big thing. It's about small, intentional habits that help to protect your emotional well-being. So that scheduled disconnect really helps you put some boundaries in place. The mindfulness really helps you build that awareness and that sense of regulation. And then the apps will really help you kind of stay consistent. And then the physical, social, creative outlets can help you restore some sense of boundaries. So hope that's helpful in terms of continuing to take care of yourselves and protect your own wellness.
Thank you so much for that information. Thank you to our subject matter expert, Dr. Irma Perez. Thank you to our lead clinical consultant, Dr. Mutsa Majiro, for their guidance, their insights during the learning community. I know we've all learned a lot of practical applications for the solutions to vicarious trauma. I wanted to briefly mention the journal prompt that we had discussed during session 1, which was what wisdom or encouragement would you offer a new provider entering the field in relation to vicarious trauma or job stress? I just wanted to name that because I know we're running out of time here, but just so that we have that on our mind. I also wanted to kind of briefly skip over our Q&A and just mention to you all how in a few slides how you can submit any questions that you might have in the future. But before that, let's go through our session summary here. We've learned a lot through the learning community. I want to give you all a quick recap. We learned about the lived experiences of behavioral health providers with vicarious trauma and job stress from Dr. Irma Perez's research. We identified evidence-based strategies aimed at addressing vicarious trauma on both organizational and individual levels. And then we collaborated in those breakout sessions to discuss our own solutions for managing job stress and to learn from others in the field too. Before we do close out, I want you all to take a few minutes to scan the QR code that you're going to see on the screen or you can use the link that we're going to share in the chat to complete our survey, provide any feedback on the learning community. Just a reminder that we will be emailing all of the materials from today's session to everyone who's joined today. Again, if you didn't have a chance to register, you can put your name and email in the chat and we'll make sure you get that information. And then I just want to invite you all to check out the RMTAC website. That's rmtac.org. You can find self-paced online learning modules, and you can also find there how you can submit a consultation or technical assistance request. The webpage looks exactly as it does on the slide here. And that's where you can submit any questions that you might have as we kind of end here in this learning community. But you'll see that button as soon as you log into our site, and you can complete the form that pops up. And I also wanted to mention a few other services that RMTAC has to offer. Aside from these learning communities that we host throughout the year on different topics related to the behavioral health needs of refugee and resettlement communities, we also have webinars that cover a broad range of topics, and we have one upcoming on December 17th that's going to focus on environmental sensitivity. So if you're interested in additional information around that content, you can also check out our online learning modules. You can register for our webinar, and you can register for upcoming learning communities all through the website rmtac.org. And then again, just a reminder that if you do want to reach out to RMTAC for technical assistance or consultations, you can submit that CTA request through the website. And I just want to close out today's session by taking another moment to thank everyone, our participants for their engagement, our subject matter expert, Dr. Irma Perez, for her insight and her expertise on the topic. And then, of course, our facilitators, Luz, Dr. Z, Dr. Mutsa, for facilitating great discussions. And thank you to the RMTAC team, especially our producers, for their hard work in making this a success. I hope you all have a wonderful rest of your afternoon. We are putting additional links in the chat so you can complete our survey. You can get a direct link to submit a consultation and technical assistance request. And I believe there was a question in the chat that was answered. But if there's any additional questions, please feel free to ask them through the CTA request form online. Thank you all again.